Demodex blepharitis used to be an under-the-radar disease with ineffective therapies to treat our patients with Demodex blepharitis, but not anymore. I'm Jaclyn Garlich, and we're going to be talking about Demodex blepharitis and the new innovation that we have to treat Demodex blepharitis. We'll talk about how you talk to patients, how you find Demodex blepharitis, and a few tips as well. Demodex blepharitis is an overpopulation of a Demodex mite. So this is the most common ectoparasite found on the skin, and it's normal in smaller amounts, but when there is an overpopulation or an overgrowth of Demodex mites, this results in Demodex blepharitis. Demodex can create a problem in a couple of ways. One, they have these little tiny claws that just, as they move along the eyelid margin, this creates these little microscopic abrasions, which creates inflammation right on the lid margin. They also transport bacteria in their gut and on their surface, and this can also cause an inflammatory response.
A study by William Trattler and colleague across 6 eye care clinics in the U.S. shows the prevalence of patients with Demodex blepharitis. Approximately 58% of all patients, regardless of visit type, were found to have Demodex blepharitis, an unexpectedly high prevalence. 55.7% of cataract patients have Demodex blepharitis, which can negatively impact the precision of IOL power calculations and the outcomes of cataract surgery. Additionally, 58.9% of patients undergoing treatment for dry eye disease also present with Demodex infestation, suggesting that undiagnosed Demodex blepharitis may contribute to persistent dry eye symptoms despite conventional therapies. Furthermore, another study led by Witold-Tarkowski indicates that 92.86% of patients experiencing soft contact lens intolerance were found to have Demodex blepharitis. Recently, the Intrepid Eye Society developed a practical algorithm for improving eyelid margin health. Accurate diagnosis and management of Demodex blepharitis are key elements of this algorithm. Let's take a closer look at the blepharitis treatment tree and how we determine the next steps. We begin by evaluating whether the patient has blepharitis. If the patient does not have blepharitis, continued monitoring is recommended, particularly for individuals with rosacea or meibomian gland dysfunction, both of which can contribute to eyelid inflammation over time. However, if blepharitis is present, we classify it further into one of 2 main subtypes: scurf or staphylococcal blepharitis, which is characterized by bacterial debris along the eyelid margin, and Demodex blepharitis, which is identified by the presence of collarettes, indicating Demodex mite infestation.
One way that you find Demodex blepharitis is actually a very simple thing that you're probably already doing in your slit lamp exam, but it's having the patient look down. And what you're looking for are these collarettes, this collar right at the base of the eyelash. This is pathognomonic for Demodex blepharitis. And all this is telling you, you can go a step further and epilate the lash and look under a microscope, but you really don't need to. This is pathognomonic to say that you have the presence of Demodex in the lash. So the collar is just at the base of the lash. It is the easiest to view when the patient is looking down. So a lot of times we'll start our slit lamp exam with the patient's eye closed. Sometimes I think that gives us a little bit of an issue if a patient has a lot of dermatochalasis that can cover the base of the eyelash. But having your patient look down, bumping up your mag a little bit, and just do a sweep of that up of the base of the eyelash is where you'll see those collarettes present.
Once we have identified Demodex blepharitis based on the presence of collarettes at the base of the eyelashes, the next step is determining the appropriate treatment approach.
prior to the approval of lotilaner, we would all sort of use over-the-counter options that contain tea tree oil to try to eliminate the Demodex mite. What we really found is that this wasn't that effective. You really need a higher concentration of tea tree oil for that to be effective and kill those Demodex mites. So oftentimes I would see a patient 1 year that I wrote the note has Demodex blepharitis, and I'd recommend a lid scrub. And the very next year they'd come back and I'd say, Demodex blepharitis, and I'd recommend a lid scrub again. One con to a tea tree oil wipe is that oftentimes it's not comfortable for the patient. It can really sting when patients use these wipes, so then you run into an issue with patient compliance. So these really weren't effective options for us. There's also some practitioners that will use hypochlorous acid spray, which is a natural antimicrobial, and that does decrease the amount of bacteria, which is the food source for the Demodex mite. But in reality, that's also not getting rid of our Demodex mite. So these over-the-counter treatment options haven't been that effective. Sometimes doctors would prescribe erythromycin ointment as a way to smother the Demodex mite and try to kill it, but this also hasn't been proven to be effective at really eliminating the Demodex mite, which is the root cause of Demodex blepharitis. Now we have the approval of lotilaner, which is the first and only FDA-approved treatment for Demodex blepharitis. And the dosing of lotilaner is unlike many of our other, chronic therapies that we're giving in ocular surface disease patients that are to be used in perpetuity. In this case, we're using it just 6 weeks. So it's twice a day dosing for 6 weeks, and it's really getting to the root cause of killing the Demodex mite.
Based on the Intrepid Eye Society practical algorithm for Demodex blepharitis treatment, the standard protocol includes a 6-week course of lotilaner 0.25% ophthalmic solution, the first and only FDA-approved treatment for Demodex blepharitis, specifically designed to eradicate Demodex mites. Additionally, daily lid hygiene is crucial to prevent reinfestation and maintain long-term eyelid health. Once treatment has been established, it is important to assess whether the patient also has ocular rosacea, as this condition may require additional interventions. If ocular rosacea is present, treatment may need to be intensified with intense pulse light therapy to reduce inflammation and improve outcomes. Additionally, microblepharoexfoliation can be used to remove accumulated debris, although this procedure is often not covered by insurance. If ocular rosacea is not present, treatment remains focused on mite eradication, lid hygiene, and patient education. IPL may still be considered, and patients should be educated on avoiding triggers and improving skincare to maintain long-term eyelid health. Regardless of whether the patient has bacterial blepharitis or Demodex blepharitis, all patients should receive education on the importance of lid hygiene for long-term prevention, nutraceuticals that support eyelid health, and strategies for maintaining a healthy eyelid margin to reduce recurrence.
In their clinical trial data, the average baseline Demodex blepharitis patient had roughly collarettes on roughly 100 of their lashes on the upper lash line. And they found that after the 6-week, twice-a-day dosing, that those patients meeting their primary endpoint, which was 2 or less collarettes, was achieved in 50% of patients. So half the patients went from 100 collarettes down to 2 or less. And then in a post hoc analysis, they looked at the clinical significance of what if there was 10 or less collarettes? Is that still clinically meaningful? And what they found is that 85% of patients that went from, on average, 100 collarettes per eyelash down to 10 or less, in addition to all of these other really wonderful statistics, is eyelid erythema was also a secondary endpoint. And oftentimes, patients are bothered by the cosmesis of red-rimmed eyes, and they want a way to improve that. And so in the clinical trials, after the 6-week, twice-a-day dosing, 25% of patients had erythema cure that were found in the clinical trial. So when lotilaner first was FDA approved, I saw the really powerful clinical data that were the results that we would see out of these patients. And sometimes, in my experience, I think sometimes the clinical trial data is not always reality. So when I started prescribing this for patients, I would see them back in 8 weeks just to more prove to myself this drop does actually work as it says it will. And that was resoundingly the reality that I saw in these patients. I would see them back in 8 weeks, and there would be such a staggering difference between the presence of collarettes before and the presence of collarettes after. Whenever I see a patient that has Demodex blepharitis, I'm often asking them if they haven't already told me about symptoms. And the common symptoms I hear are itching right along the lash line. Typically with an allergic reaction, we're seeing itching more in the inner corner. So this is more specific to that lash line, or sometimes crusting when they wake up in the morning, so crusting on their eyes. And so treating our patients with Demodex blepharitis with a product like lotilaner is really getting to the root cause. And when I explain to a patient, you have Demodex mites, but I actually have a treatment that's going to improve and eliminate these Demodex mites in just 6 weeks, patients are very much on board with trying to get to the root cause of the problem. So we already talked about how to diagnose Demodex, which is the easiest part, in my opinion, of this whole process. The harder part can sometimes be educating a patient that they have a mite in their eyelash. And I have found that the most effective way to do this is really just to normalize that. So I tell a patient, there is normal stuff that lives on our body, normal bacteria, normal mites. But when there's an overpopulation of that is when we start having your symptom of whatever that symptom is, whether it's itching on the lashes. And so I just normalize that discussion with the patient. It does nothing to do with someone's hygiene or how well they're caring for themselves. It can just be an overpopulation of these mites. And the really wonderful thing is that now when I talk about it, I have a treatment to give you that will eliminate those mites. So that has been, my feedback from patients has been very positive because I actually have a solution to this problem. One of the biggest things is oftentimes we're asking patients to use drops, chronically for our ocular surface disease patients. And because this is a 6-week dosing, this is a little bit of an unusual duration of how long a patient is using a drop. So I think keeping track of that could be a little bit of a challenge for patients. I ask a patient, please write it on your calendar when you started using that drop so that you know when you're actually done with the drop. But it is still a twice-a-day dosing, which is really easy to incorporate into someone's natural habit of brushing their teeth morning and evening, which is when I advise a patient to use this. So oftentimes we'll see Demodex blepharitis present in a dry eye patient. And dry eye patients, they have lifetime therapies. So we're asking patients to maintain, to use a drop chronically. And the beauty of Demodex blepharitis, the treatment with lotilaner, is that it is just a 6-week drop. So, and at the completion of that, we've eradicated all of these mites and we've improved eyelid erythema in just 6 weeks. My tip for everyone is to really start actually looking for Demodex blepharitis. It is so easy to see by having your patients look down, bumping up your mag. When you really start looking for these collarettes at the base of the eyelash, you'll end up seeing them in more patients than you think.